I would like to make a brief comment, really, a brief statement. Would I be able to do that?
Yes, indeed.
Well, I've written it down, so I didn't want to miss any of the important point. I firmly believe that the most devastating experience for a doctor is to witness harm inflicted on his or her patient that resulted from treatment the patient had received. Now, this feeling of devastation is felt regardless whether the harm occurred unintentionally and even if the harm could not have been foreseen.
This statement was read out by Dr. Saad Al-Ismail at the conclusion of his evidence at the UK Infected Blood Inquiry in November 2020. Dr. Al-Ismail is a consultant haematologist in Swansea, Wales. His words convey the terrible distress surrounding the events of HIV transmitted by treatment in haemophilia patients in the 1980s. Dr. Al-Ismail started his consultant role in 1982, the year when the first cases of AIDS were reported in haemophilia patients. I am Mallika Shekhar, a haematologist in London, UK. Welcome to my podcast series called The Bitter Pill, that looks at lessons that we doctors may learn from history. This podcast is called Uncertainty and the Fallout. Let's go back to the beginning. AIDS was reported in homosexual men in mid-1981. A year later, 3 American patients with haemophilia were reported with AIDS. Since the 70s, haemophilia was treated with factor concentrates made from large volumes of pooled plasma. This improved survival and returned a sense of normalcy to patients' lives. But in 1983, there was also a report of AIDS in a baby who had received blood transfusion, and this caused concern about the iatrogenic nature of AIDS. At that early stage, there were doubts about the etiology of AIDS and also doubts about the potential natural course of AIDS in haemophilia patients. We start with Professor Christine Lee. She was a consultant haematologist at the Royal Free Hospital in London in 1983. She describes the thinking of haemophilia doctors at that time. The extracts in this podcast are drawn from the YouTube recordings of evidence given under oath at the UK Infected Blood Inquiry. Individual doctors are questioned by counsel Jenny Richards and the chair of the inquiry, Sir Brian Langstaff.
I think this is January 1983. Yes. You rather suggested that everybody knew that AIDS was a problem in January 1983. And I don't think that is true. It is certainly true that there were cases of AIDS that had been reported in people with haemophilia, but there was still debate about whether those cases were a problem because of the immunological damage that concentrates had come and made some people more sensitive to AIDS.
In June 1983, the World Federation of Haemophilia meeting was held at Stockholm. This meeting was a fixed point of reference in many people's memories of these events, years down the line.
So it's like... But what I'm saying to you is the idea that everybody knew everything at that stage is wrong. And I'm trying to also, the memory, the really powerful memory I have, mainly because it was the first international meeting I'd ever been to in my life, was this emergency meeting in the lunch hour, an hour's meeting of haemophilia treaters, patients and doctors from all over the world. It was an ad hoc meeting. It wasn't even in the programme because people were trying to report their ideas. People were still discussing, is everybody going to get it? There's no doubt that some people had got it, but it's certainly not clear that everybody was going to get it.
The discussion that took place that you referred to, the debate at the World Federation of
It wasn't a debate. It wasn't a debate. It was a presentation, and what I was trying to say that there were different views presented.
Can you recall whether there was a majority view that the condition was likely due to an infectious agent?
There wasn't a vote taken or anything. What I do remember, I got my slides upside down. Which is perhaps why I do remember it. And the other thing that's quite interesting here, I mean, there is such a parallel with COVID-19, isn't there? Because we're talking about there may be a vaccine. Well, of course, there never was a vaccine because it's a carrier state. But we never had any idea of that then. So I don't think, people now with COVID are talking about we have a vaccine by Christmas, maybe. We don't know. And I really do think it's important to try and understand that it's very easy with looking retrospectively, but it's very difficult to remember the confusion, the lack of knowledge at that time.
This is probably one of the most iconic ad hoc meetings in medicine. The analogies with COVID is a recurring theme, except that there was no internet and technology was less well advanced. But just consider the case of the vaccine. To take up Prof. Lee's point, yes, we did have a vaccine for COVID-19 by Christmas 2020. But the inequity in vaccine access takes society right back to its pre-HIV days. One of the important outcomes of the HIV era was equitable access to treatment. In the rampant vaccine nationalism of 2021, this principle has taken a backstage. Let's return to uncertainty. We hear Dr. Al-Ismail on the subject of a doctor's attitude with their patient when things continued to be uncertain for years.
The number of patients who are going down and unfortunately succumbing to the infection initially were very small compared with the positivity in terms of antibody. And we thought that, we hoped that it is going to be something which is not that disastrous. Unfortunately, we all were proven wrong. And I think that is, in a way, that was the tragedy, really.
Do you think that you collectively erred on the side of optimism?
Yes, I think the reason why we erred on the side of optimism is because, if you like, by the time the test became available to us, and as I said, all the patients with the first lot of testing proved to be positive. And that was the only thing you could do, in the sense that if you did not err on the side of optimism, it would have been very difficult to continue with one career, really.
There was uncertainty related to cause and to outcome. And many doctors veered on the side of optimism, hoping for the best. When things became clearer and tests were available in 1985, there was helplessness because until the effective HIV treatment started in the early 1990s, there was little to offer. So without an optimistic attitude, they'd have had trouble continuing in their jobs, in their careers. There was nothing to offer to patients other than incomplete information and hope.
There isn't a treatment. There isn't anyone who will tell you in which path these patients are going to go. At least in hematological malignancy, you have so many parameters that you could plot, and you could say to the patient, this is the patient in the very high risk group, this is the patient in the low risk group. You didn't have any of that. The only thing you had was to watch and wait. It was only when the real treatment came in that we could see the light at the end of the tunnel. Prior to that, it was terrible.
Let's hear from Dr. Ian Franklin from Birmingham on reassurance. Reassurance is an important tenet of being a doctor. How does it work with uncertainty?
The phrase "our efforts to reassure" might suggest that you were trying to reassure patients not to be too worried about this.
Well, reassurance is a word that comes up frequently from that era, doesn't it? The information we were getting from the Haemophilia Centre Directors Organisation was to carry on using the treatment, that it was highly unlikely that many people would get AIDS. All these things are wrong, but that was what was coming out, and that was what seemed to me to be the message. I think the true likelihood of getting AIDS from someone who was HTLV3 positive couldn't have been anticipated at that time, maybe the worst possible scenario. And you can say reassurance is a sort of panacea and go away and don't worry your head about it. But I think there are other meanings. I think when we were getting the positive tests back, I think there is still a role for reassurance in trying to let people know that we will continue to look after them. Mark Winter mentioned patients who have been felt abandoned. I think we did reassure them that we would be continuing to look after them and deal with the issues. But yeah, it's a word that can make it sound as if you're just trying to fob people off.
The stance of reassurance is fundamentally important in our communications with our patients. To reassure a patient on a specific question may be possible. For example, this lymph gland feels normal, but we need to biopsy it. Or, this biopsy seems normal, but we need to follow it up with a repeat scan. Such specific reassurance may not be possible, as was the case with AIDS, because there was a lack of clear knowledge. Reassurance has to deal with anxiety, and really what the patient wants to hear could well be that it's all good, you're perfectly all right. That level of general reassurance may end up creating a myth of certainty, what Dr. Franklin refers to as fobbing the patient off with a myth. The language used in communicating the facts of the situation may need metaphors, but to hedge facts, to euphemize the situation, may end up contributing to the problem of unjustified general reassurance. Some communications have the luxury of time, and some don't. Some communications will need to prioritize not distressing the patient, while others may have scope for straight speaking. So reassurance is really not as simple as it appears. Dr. Franklin alludes to another fundamental aspect of reassurance to facilitate the next steps as a carer, that a patient does not feel abandoned. Let's move to Dr. David Bevan from London, when he was a trainee at St. George's Hospital, describing his conversation with his consultant, Professor Flute. The trainees are taking their exams, and Professor Flute edits the British Journal of Haematology. They are therefore both well informed. What does Professor Flute think about these early cases of transfusion-transmitted AIDS?
Can you describe for us that conversation that you recall you having with Professor Flute?
We were sitting in the haemostasis laboratory preparing for the MRC-PEV, and therefore we had a moment where Professor Flute took us through what we'd learned. And as part of that discussion, we raised it with him. Had he read this, did he not think that this was a transfusion-transmitted condition for which all our haemophiliacs would be at risk of, particularly those who were receiving American concentrate? And I just remember his response. I think it was a sunny day, and he was sitting by the window, and he was, in his usual way, kind of gruffly, jovially, said that he didn't regard this as in any way a proven infection. At that time, he was an editor for the British Journal of Haematology, and he said he'd seen recent submissions of papers showing similar disorders among T-cell subsets in a bone marrow disorder known as myelodysplasia, which has nothing to do with haemophilia, and who are not treated with similar blood products, but do get a lot of red cell transfusions, sometimes platelet transfusions. And he said that as far as he was concerned, the findings in the American group were just typical of people who had received any kind of transfusion therapy on a regular basis. That it was, if you like, an immune system adjustment to being exposed to other people's blood and their HLA antigens and other foreign antigens in that material. So he went into some detail, and then as a second part of the explanation, he explained that in no way would he take any action in terms of changing infusion practice in haemophilia unless there was official firm guidance from the UK HCDO so to do. And at that, as was a bit typical of Colonel Flute, the discussion was over.
So Dr. Bevan's consultant, Professor Flute, was aware, and like Prof. Lee and Dr. Al-Ismail, is trying to weave the data together to form a clear picture. But in practical terms, these alone are not a call to arms. The experts haven't issued any specific bans on treatment continuity. It's a risk versus benefit approach where the risk was unclear, or possibly, because it was unclear, it was deemed low.
But the fact is, I think that they held the line to the point where it almost became like denial into 1983. I'm still rather amazed by the fact that that assumption that they were looking at a harmless phenomenon was sustained. It just doesn't seem to make any sense to me. Doctors are usually accused of over-exaggerating dangers rather than the reverse. I think that's probably our role. Concepts like that of the precautionary principle did not, to my knowledge, exist then, certainly not in medical practice or common parlance. The idea that you would actually take action in respect to perceived dangers, even if those perceived dangers were relatively remote or not defined.
The approach after HIV changed to a more rigid response to risk, the precautionary principle. This characterized public health approaches for many years after HIV. It was risk-averse and has been criticized for being anti-innovative, stifling emergency response, and so on. The recent COVID pandemic has been characterized by many governments, including UK, for not using the precautionary approach at the outset and through the next 12 months of the pandemic. Dr. Bevan's appraisal of his senior colleagues is clear. How could they be in such a denial? But how does it square with their own accounts? Here is Dr. Anna Pettigrew, a clinical assistant from York Hill in Glasgow, discussing about the flow of knowledge at that time.
State of knowledge at the time. Can you help me with this? One of the questions that I'm going to have to answer at the end of this inquiry is what I make of the state of knowledge. It might be the state of knowledge of an individual clinician, but the way you're using those words there, you're talking about the state of knowledge generally, aren't you?
I think both.
Well, how do I work out what was the state of knowledge generally, do you think?
I think the state of knowledge held by a consultant or director of a haemophilia unit who was attending HCDO meetings and being a party to reports would have more knowledge and would be up to date with the state of knowledge at the time. For instance, the state of knowledge, as you say, of the junior person would be dependent on that knowledge being passed on or that junior person finding out that knowledge for themselves.
You could only tell a patient what you knew, what your state of knowledge was, but you're talking here more generally.
Yes, and I think that refers to the fact that it was an evolving situation with regards to AIDS. I think, again, a parallel to the current COVID situation, the knowledge about COVID has increased over the last 9 to 10, 12, nearly 12 months as we've learned more about it. And it was the same, I think, at that time. It was an evolving situation. It was an unprecedented situation, and knowledge about the condition was accumulating all the time.
If you're right, that it must, in this context, mean the knowledge by directors who derive their knowledge from the UK HCDO, the knowledge which the body of those who are said to be experts in haemophilia care ought to have. Is that fair?
I think that's fair, yes.
So that would depend, would it, then on them disseminating that knowledge to everyone else in if you like, the tree of care?
Yes.
Because you could only tell the patient either what you had discovered independently, which I imagine if you did, you'd want to check with someone else anyway, or what you had been told through this, as it were, chain of communication.
I think that would be correct, yes.
So it would follow that there would, in general, there ought to be some system for continuing education information to staff who are dealing with matters at a specialist level. Would that be fair?
Yes, and I think there was more discussion at that sort of level after 1983 in the department.
The discussion here deals with two aspects. One, the nature of knowledge. It's true that there was a higher level of knowledge within the Haemophilia Centre directors through their network organisation, the UKHCDO. But nationally and internationally, multiple viewpoints prevailed, and these evolved with different velocities. There was data and interpretation of data, but also bias and national perspectives. So while the experts knew, they did not always agree. The second point that Dr. Pettigrew talks about is the dissemination of knowledge within the team. Her actions were based on her consultant's views and practices. In current practice, trainees are supervised more closely and the consultant responsibilities are more explicit. Trainees also bring in their own experience from other institutions, including the tensions of differences in treatment approaches. Let's move to some specific challenges of looking after children. How do doctors deal with breaking news of AIDS to children with haemophilia?
Anyway, at this conference, I was the sort of follow-up after the talk that said, we don't think you should tell. My talk was why you should tell. We discussed it a lot with other people. The argument seemed quite clear, really. If adults have rights to know, so do children. I felt it was a very dangerous situation not to tell. I felt that many of the children probably suspected anyway, or would suspect. I felt it was better to be honest and tell them. They would say, if a doctor tells me news like that, I can always believe what they're telling me. So I decided to tell and I had a counsellor by this stage. We just sat down one day and said, how are we going to do it? And we thought we would just, the basic, again, no guidelines, nobody advising us. We just said, well, let's do basic principles. Let's just do it briefly when they're well, in the school holidays. Let's follow it up with a quick appointment. So once we'd got an agreed thing of what was our view, the next step was I approached all the parents and just on their own, both of them, and told them the results of the test, which was obviously very distressing. And I said to them, it's our view, we need to tell the child. There were some exceptions. There was a boy who was 4, so we didn't tell him. I just want to go on a moment.
Yes, of course.
I'm just having a moment. So We then sat down with the parents and said we'd really like to tell, and got varying responses, really. One or two of the parents were very, very reluctant. It was too distressing to think about. But eventually they had all agreed. And so we then went on, and that's what we did. We told them in the way in which I just outlined to you, and then they all knew, apart from the very young child.
In many respects, patients with haemophilia had belonged to a support structure that helped them through the crisis. Other groups of AIDS patients, for example, the gay community, formed a collective only as a result of this crisis. They forged a new identity. This was important in how activism and lobbying worked. In haemophilia, doctors had lobbied for many years to introduce and use factor concentrate treatment. Here, Dr. Winter describes his advocacy with the school.
In the information you were giving to your patients at this time, you told them not to inform too many people, not to share the news too widely. Is that correct?
Yes, this was a time of great stigmatisation, as if there was not enough for the patients to bear. I mean, we had people who had windows smashed. We had somebody went into a laundrette and they wouldn't clean their trousers because they knew they had HIV. We had kids on the school bus chanting, "You've got AIDS." There was widespread stigma. So we said to the patients, we really advise you to be careful who you tell.
And in terms of the stigma specifically in relation to children, your statement refers to schools reacting particularly badly. Can you just explain about what happened in relation to that?
Well, all of the schools said, we can't have this child anymore. It's not possible. For a variety of reasons that were given, one of the schools produced a long document saying he couldn't go on the school bus because he might bump into somebody and bleed. He couldn't have lunch because he might stab himself with a fork and bleed. He couldn't do pottery classes because he might scratch himself and bleed, and so on and so on. There was an especially difficult encounter with a school where I was trying to get a child in who'd recently come under my care, who extraordinarily had never been to a normal school because of his haemophilia, a practice that had been abandoned sort of 10 years previously. And this school was adamant they would not have this child, and there was a very, very spectacular series of meetings with the school and the education authority. Eventually, the education authority agreed to employ a nurse who sat alongside the child, holding a burn bin and a bottle of disinfectant, wearing gloves, so that if the child had a nosebleed, she could clean it up. And I obviously very vehemently protested against this because, the whole thing was completely inappropriate and the child was being stigmatized in a very dramatic way. So things did settle down after a bit, but yes, it was a very difficult initial exercise trying to get the schools to accept the children.
We have walked through the ways in which uncertainty affected practice in the early 80s. We've heard how people thought through those years, how knowledge was handled, how they communicated with their patients, and how advocacy worked. Let us listen to some accounts of the fallouts of these events. We started our podcast with Dr. Al Ismail's statement, where he talked about the devastating nature of medical harm. It's a nuanced statement. Medical treatment is not harm-free, and when we treat a patient with chemotherapy or surgery, and our patient dies of a complication, it is sad. It affects the treating team. But harm that moved in imperceptibly, as HIV did, was a different level of distress. We end this podcast with views of some other doctors.
Oh, I think it was the most terrifying phase of my professional life because of this feeling that it was running out of your control. I mean, even in leukemia and cancer situations where people have become profoundly immunosuppressed, you felt a certain degree of trust in the drug regimes. But in the HIV, it seemed to be running out of control. You might get the opportunistic infections under some kind of control, then along would come bizarre versions of Hodgkin's disease or lymphoma in the brain and elsewhere that would eventually you would not be able to treat. Very, 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 very alarming. I mean, to me, it brings great sympathy to the intensive care doctors trying to deal with the first wave of COVID pneumonias, where clearly that it was something different from what they'd ever seen before. And they've learned how to manage it, and I think probably the HIV doctors did as well.
I wrote to Kenneth Clarke when he was Minister of Health to ask that the government offer no-fault payments and support for the patient. And I wrote to various other MPs in both parties to promote this. And I can say all haemophilia treaters were put in an awful position, having a pile of writs saying we were incompetent with patients that we had loved and looked after. As you see, it was awful, and it made me wonder what on earth was going on at the Department of Health. Here they were funding the health service, trying to support patients, at the same time driving a wedge between a group of very vulnerable patients and their treaters. This was all a terrible tragedy, a regrettable, terrible tragedy. But I do have a difficulty with some of the statements that come from members of the government. They say that the events should never have occurred, implying that HIV and HCV infection should not have occurred. For prime ministers to make those statements shows to me a paucity, to put it politely, of understanding of the history and the difficulties of the last 50 years. And I'm disappointed when they speak in such terms.
In 1937, the life expectancy was 20 years. Towards the beginning of the 90s, it was approaching 70. And this was at the cost of having hepatitis and, sadly for many people, HIV. But the other side of it was people lived a life. And I truly believe that people at that time were doing what they thought was the best, and the side effects were really not at all clear, and certainly HIV was a tragedy that nobody could have foreseen. And of course the other thing is this lethal combination of HIV and HCV, and the majority of patients progress so fast to liver failure. We couldn't have seen that. I think it is right for any medical treatment, if it causes harm that wasn't expected, the patient should be supported. But I think the idea that anyone who is a decent person would give somebody some treatment that they knew would cause harm is frankly ridiculous. And it's actually quite hurtful for those people, those many people who care for patients. These people have always been part of my life. They're still part of my life. I sometimes see them. I've got an ornament of a Greek student who died on my shelf. Every day I see that, and I see this man. It was the saddest tragedy of all. But I think to suggest culpability is wrong. Sorry, my speech is over, but it does upset me.
Professor,
I've been one of my Rule 9 things that said I killed somebody, and that is it is so hurtful. And then I think, well, I'm pathetic. These patients have got far more problems than me. Why should I feel pathetic about that? But I do. I feel totally hurt.
I heard Dr. Saeed Al-Ismail say in his final statement to the inquiry, and he said, "I firmly believe that the most distressing experience for a doctor is to witness harm in his patients from treatment received. This feeling of devastation, even if harm was unintended and unforeseen, is shared by my colleagues who look after patients with haemophilia. I agree wholeheartedly with what Dr. Ismail said. However, I know that any distress felt by those involved in treating patients with haemophilia pales into insignificance compared with the dreadful and enduring suffering of those families affected by this tragedy. To my mind, there's no greater tragedy for a parent than the loss of a child, and to watch that child suffer and die from a dreadful illness, and often because of the associated stigma, without the support of the extended family and friends. The effects in the families were far-reaching. There were long-lasting emotional and physical problems, not only in the children affected, but in their siblings and their parents. This was a terrible tragedy, and I am truly sorry for the suffering that they endured and they continue to endure. Thank you.
In these accounts, tragedy and sorrow dominate, but three important themes emerge. Liability is one. The nature and value of apology has been modified over the years by its impact on admission of guilt, admission of liability, and culpability. These events provide an example of where treatment was provided in good faith, with use of data as were available at that time point. Many countries acknowledged this as such, and the notion of blame was handled differently by different countries. Blame, described so movingly by Professor Lee in her account, when it feels unjustified, is deeply hurtful. The second theme is the impact on doctor-patient relationship. Professor Ludlam expresses a feeling of being left high and dry by the UK government, who drove a wedge in the therapeutic relationship. There was also underinvestment for self-sufficiency to manufacture factor concentrate and the infrastructure to promptly and humanely deal with this crisis at individual patient level. One of the fundamental outcomes of the HIV crisis was a change in the therapeutic contract, with patients better informed on the science of treatment and their choices of treatment, wishing to lead decisions rather than be forced to choose one offered to them. Thirdly, there's the theme of the doctor's victimhood. The doctor who has suffered the consequence of harm has been described as a second victim in medical literature. This term has been contested as inappropriate. It removes agency from the real victim, which Dr. Pettigrew describes to us with such clarity. And finally, to err is human was a phrase used by the poet Alexander Pope in 1711. It's also the title of the American report published in 1999, To Err is Human, Building a Safer Health System. It's interesting to draw comparisons between the 1980s crisis and the COVID-19 pandemic, especially in the lessons not yet learned. Thank you for listening to this podcast. Goodbye.